Tell you the format of our panel today. I'm going to be introducing each of our speakers, and when I'm done, I'm going to give them each about 5 minutes. And they laugh when I say that, but we're going to try to give them about 5 minutes to tell us about their work, to give us an overview of their work. Afterwards, I will attempt to moderate a discussion that will then segue into a little bit of Q&A with yourselves. And I've been told that the contact information for these organizations represented up here on the panel today are on the back of your program, so please take a look at that. So this is who we have in the house today. I must say it's one of the most diverse panels of expertise that I've ever moderated, so I'm very excited about it. We have Robbie Clark, maybe that person could signify there. They are lead organizer of Causa Justa, Just Cause, a Bay Area organization focusing on housing, and they are a member of Black Lives Matter Bay Area. Woods Ervin, they are program and policy director of TGI Justice Project, a group of transgender, gender variant, and intersex people inside and outside of prisons, jails, and detention centers, creating a united family in the struggle for survival and freedom. Solange Gould, she is a graduate of UC Berkeley School of Public Health. We always plug that when we can. And policy unit chief with the Office of Health Equity in California Department of Public Health. Rupa Marya, she is a medical doctor and assistant professor at UCSF School of Medicine, faculty director of Do No Harm Coalition, a group of over 300 doctors, nurses, faculty and students and staff at UCSF, committed to ending racism and state-sanctioned violence. And she's just come fresh from Standing Rock this afternoon. To my immediate left, Chris Nielsen, co-lead educator at National Nurses United, the largest union of direct care RNs in the U.S. and parent organization of California Nurses Association. At NNU, he has helped develop curriculum and programs focused on health and social inequities, including a new online certificate program promoting a structural competency framework among nurses, students, and activists. Prior to coming to NNU, Chris completed a PhD in Latin American Cultural Studies at the University of Pittsburgh. Megan Rees, she is a licensed professional clinical counselor, member of Critical Resistance Oakland Power Projects, and behavioral health clinical trainer, and volunteer at Anti-Police Terror Project First Responders. We also have with us today Katherine Schaff. She is a graduate of UC Berkeley School of Public Health. Have we plugged that enough today? And a health equity coordinator at the Alameda County of Public Health. After their presentations, after our discussion and a little Q&A, we will have some closing remarks from the director of our UCB-UCSF Joint Medical Program, John Balmes, and also some closing remarks from a graduate student and member of DICE, Diversity, Inclusion, Community Equity in the Berkeley School of Public Health, and that's Pike Long. So, got a great reception out here. I'm glad everybody stayed for our closing session. And who would like to begin on our panel? Sure, let's do that. Robbie?
How's everybody doing? Cool, all right. So I'm going to take a little more than 5 minutes because, as you can see, I'm repping for 2 organizations. So I don't want anybody cutting me off before I'm done. All right. So as I was introduced, I'm Robbie Clark. I've been working at Causa Justa Just Cause for almost 10 years now, leading our housing rights campaign work, and I'm also one of the founding members of the Bay Area chapter of Black Lives Matter. Yep, give it up. So just a little bit about Cause of Who's Just Cause. That's me when my hair was shorter. So we're pretty much a community organization here in Oakland, or not here, in Oakland and in San Francisco, doing work with specifically Black and Latino communities, flatland parts of Oakland, the Mission and the Bayview in San Francisco, doing direct services, know your rights information, making sure that folks are equipped with what they need to defend themselves when their rights are violated. Our primary policy areas that we work on are around housing and around immigrant rights. And you can see more about the things that we do there. In 2004? No, that wasn't that long ago. 2007, we did the report, Rebuilding Neighborhoods, Restoring Health. And this was the beginning of when we started to make connections with the Alameda County Public Health Department and really started to put a health frame on housing and equity. It wasn't enough for us to tell the city council that Black people were being displaced from Oakland. That wasn't enough. They didn't care. Right? But when we started framing it as a health issue, then that really shifted the conversation, because what legislator wants to be like, I'm against healthy things for the community? Like, who wants to do that? But what was really important about this report was that it uplifted and it brought into the debate around housing the impact that it has not just on individual health, but also on community public health. And then the report next to that is Development Without Displacement that we released in 2014. That was also, we also had some support, research support from the Alameda County Public Health Department. And again, that was about really shaping the debate and framing displacement really as a health issue. And for us as Cause of Justa, when we talk about displacement, our work is about fighting displacement on a local level in terms of gentrification, but our immigration work is really making the intervention around the ways that people are displaced by global capitalism all throughout the world. And so we see ourselves as fighters on the front of local and global displacement. This framework is a concept that is a way that we define gentrification and the foundation of gentrification, because even though people experience gentrification in very interpersonal ways, for us to really find solutions to it, we really have to be looking at the problem systemically, right? Because it's a function of how development works and how a neoliberal ideology shapes development, and as that continues, the impact that then has on people and on communities. And so if you look at this diagram, the bottom three, it's not that cute, but it's very informative. The bottom three are the foundations of neoliberal development, right? So you have capitalist accumulation, which, how many people have heard of that before, right? Great. The state is a facilitator of capitalism, right? So we'll get a little bit more into that. And then we also have racialized underdevelopment, which is a nice way to say that racism happens, and most cities and the government usually, pass laws and policies that don't benefit Black people. Right? If you look at West Oakland, for example, and you look at the ways that in the GI money that came down to veterans after the war, you look at the fact that that money could not go into West Oakland because those federal dollars could only go to funding new housing. So that automatically meant that money went to the suburbs. And they were building highways and other ways for people to get out to the suburbs where Black people couldn't go to because of redlining, right? And they were building those highways and they were building those trains right in the middle of the communities where Black people could live. So you see the breaking up of the community. That's just been a part of how development has happened. And so you see the arrows pointing out, these are the impacts. Right? So loss of social cohesion. There's a number of studies, you all know, that connect the loss of social cohesion to impacting public health, right? Displacement, mass incarceration, housing insecurity. The list goes on, right? You all can see it. And so all of those factors are all a part of the impacts of the way that the government makes decisions when it comes to land use, when it comes to the dedication of resources. So this connects a lot to to Black Lives Matter, and when we talk about the war on Black lives, and when we talk about state-sanctioned violence. This was the action that really kicked off Black Lives Matter. That's me over there at the end, kind of like this. So that's me. And we were I was a part of the Black Friday 14 that stopped the West Oakland BART, and we stopped it on both sides, and we did that symbolically because of what BART has represented in terms of breaking up Black West Oakland. We wanted to make a statement about that. We wanted to talk about the ways, and we did talk about the ways that state-sanctioned violence doesn't just look like cops killing Black people, but it looks like the policies and the decisions that have been made and that continue to be made that disproportionately impact Black people, that criminalize poor people, that criminalize homelessness. All of these things are a part of the state-sanctioned war on Black people, which I talk a little bit about here, right? This was an action. So part of the work that we do with Black Lives Matter Bay Area is we use creative actions to educate and we mobilize people. This is an action that actually wasn't just a Black Lives Matter action. It was actually done by a group called Black Seed as a part of 96 hours of direct action. That's been something that the Anti-Police Terror Project has been leading in Oakland for years. This is about to be the third year coming up in 2017, and they did a Black Health Matters action. And the reason why they did that is because one thing that we're seeing with the murders of Black people is that over almost half of the people who are being murdered by the police are people who have mental health issues, right? Are people who struggle with mental health. And in a lot of ways, police have become those first responders for mental health issues. So, why is that, right? So thinking about that and thinking about the question of that. I also wanted to bring into this conversation a woman, Natasha McKenna, who one of the leaders in Black Lives Matter and the founder of the Anti-Police Terror Project, put on a one-woman play called Tasha, about Tasha McKenna, who was tasered and murdered by police while she was in jail in Fairfax County, Virginia, right? So this is, again, like something that happened because she was locked up. I don't know, how many people have seen the 13th? Have people seen that? If you haven't seen it, you should totally see that. I'm not going to go into prisons. I want to go off on this, but people should know Natasha McKenna, and people should know her story. There's a lot out there about it. And then I also put up the pictures of a number of other Black folks that have been killed by police. And these are all people in California, right? So we have Mario Woods, who was shot by SFPD. The Black Health Matters action that took place was right after Mario Woods was murdered. You have Alfredo Alongo, who was murdered in El Cajon about 2 months ago, also someone who struggled with mental health issues. And on the bottom, you have Michelle Shirley, who just this morning, or just yesterday, was actually shot by police in Torrance, California. And the reason why I bring these folks up is because if you think a little bit about the history of California, and I'm going to wrap it up here, you think about the impact of Reagan, you think about the impact of Reagan's policies, you think about the ways that mental health institutions were defunded, right? You think about the ways that at the same time mental health institutions were defunded, that was the same time that the federal government was passing laws saying that they weren't going to build public housing anymore. Right, so you think about all of these policies that have been passed and the impacts that it has, and then it leads to a moment where we're in right now, where people are homeless, and a number of homeless people are struggling with mental health issues, and the first people who respond to homeless people are who? The police, right? There was an encampment this morning that was broken up, right? A couple of friends of mine were arrested. Right? And so we see that with homelessness, or with mental health issues, the police continue to be the first responders. So what if those things were different, right? And I think that the question for you all to think about is, how can you use your position in your vantage point and your expertise to really start to put a health frame on the real impacts of these issues? Because when we're able to quantify the actual impacts of racism, give it via like what it looks like in people's health, then that's when people actually start to listen. That's what we learned in doing the work that I've done at Causa Justa, and I think that that's what we need to uplift. And when we talk about health, we need to be relating health to everything. Health, there is no issue There is nothing that happens in terms of injustice that does not relate back to health, right? And overall, just to keep it real, capitalism is bad for our health. It just is. And what we need health professionals to do is we need health professionals to show that, so that way we can dismantle it, tear it down. Thank you.
So, my name is Ervin, and I am the policy director at TGI Justice Project, which stands for Transgender, Gender Variant, Intersex Justice Project. And we are an organization that works with trans people both inside and outside of cages. So basically, I'm going to talk a little bit about trans people in prison. And I'm going to just see if I can talk really rapidly about that. Okay, so the way we see prison, so in general, prisons are a total institution that control every aspect of your life, right? And so prison's role in society, well, this is how we operate at TGIJP, is prison's role in society in general is to say that they are there to correct and rehabilitate, but we would argue that they, along with policing as well, are instruments that produce social death through the removal of things that allow for your social reproduction, whether that be community interaction, political power, so you can't vote when you've been incarcerated, or like access to jobs, self-determination in general, right? So it's a producing social death. That's the apparatus. That's what it's meant to do. So this has a specific impact on trans people. So prisons are situated as binary institutions, and the system is based on genitalia. This has all sorts of implications on trans people inside. First, we know that humanity comes in a variety of genders as well as a variety of bodies. So situating people in binary institutions is inherently violent. And this plays out on trans people in a variety of ways. So until recently, in the state of California, trans people would be housed by default in solitary confinement for their own protection. And so solitary confinement or administrative segregation it has a lot of impacts medically, which include hypersensitivity to stimuli, perceptual distortions and hallucinations, increased anxiety, fears of persecution, heart palpitations, headaches, confusion, like a list goes on and on and on, because the fact of the matter is nobody is meant to be in a cage, and especially not these extreme cages, which are these tiny boxes, almost 24 hours a day without any contact. And so while we're talking, and so this is what trans people have until recently been primarily subjected to when inside of state and federal and local facilities, until that being the 2011 and 2013 hunger strikes across the state of California, which are in the process, which shifted how folks inside are housed. A lot of those people are being pulled out of solitary confinement and into general population, which now I will get to. So while we're talking about mental illness, 66% of state prisoners and 45% of federal prisoners have mental illnesses, according to the Bureau of Justice, Statistics. On top of this, psychiatrists who are located inside of prisons play a huge role as gatekeepers for trans people. Period. In addition to the deputies and the wardens. So while people inside are experiencing these general psychological impacts of confinement, and then they get they have these like these intense impacts of solitary confinement, that those can be diagnosed in a myriad of ways. Your mental health, whether it be in solitary confinement or in prison in general, can be diagnosed in a myriad of ways. A lot of times diagnosed as personality disorder, which is difficult to get rid of as a label inside of CDCR, California Department of Corrections and Rehabilitation, and follows you throughout the system, and then keeps you from getting, keeps you from access to programming, which bars you from being able to get out, right? It makes it so that when you go up for medical review when being trying to be paroled, before the parole board, it's less likely for you to be released. So essentially, the role of prisons, as I'm going to continue to reiterate, is that isn't to heal you, but to control your movements. So you get oftentimes psychiatrists inside will prescribe psychotropic meds for treatment, which honestly isn't. It's not for the healing of the folks inside. It's more for the controlling of the management of their compliance, right? And so this environment, and the idea is not that prisons and jails are healing either. We'll get to that in a second. And that because that they're inherently traumatizing from the jump. So for trans people, should you choose the complicated process of trying to get yourself classified as trans, which is, variety of genders, variety of bodies, in order to get access to gender-affirming clothing and hormones, which can help mitigate trans-related gender dysphoria, then there's all of the harassment that comes with that, from guards, misgendering, not being using the appropriate sort of formal title, Mr., Miss, all of those things. And then there's the staff actually intentionally messing with your access to your clothing, whether it be wrong kind of binder, wrong kind of underwear, wrong kind of, and then they will actually mess with the dosage of your hormones, which if you have ever taken hormones for any reason, throws it messes your head up, right? And so that's on purpose. Why, you may ask, is because the CDCR is trying to, their corrections and rehabilitation, they're correcting your gender. That is what they are trying to do while inside, according to society. So the priority is to not allow people to have self-determination over their gender while inside. Self-determination in general. All of I mentioned earlier that there were issues related to healing and prisons and jails. So there's this shift around the idea of having mental health jails. So we're seeing that in Alameda County. We're seeing that in the assertions around the SF jail project that TGIJP was a part of fighting to stop from occurring. Thank you. And so what the assertion that a jail can be a healing environment, as part of the fight, both in terms of the jail project that San Francisco was thinking of putting together, that was both posited as a jail where there would be gender-specific pods for trans people, which would be therefore, more, that they would provide relief, but that also sets trans people up for targeting, because then you're all together, and then it's harder for other people within the facility to come to your aid, because then you can be targeted by guards there. And then also it was posited as a mental health jail. TGIJP, part of the SF No New Jail Coalition, fought back against this and demanded what we really need to make our San Francisco safe: housing, healthcare, access to food and clothing, the things that actually promote health in community. And so this is all while I think the interesting thing about political priority around the jail in San Francisco, when you watch, is this this idea of what are prisons and jails for in terms of administrative capacity. So San Francisco was willing to spend $28 million on a new jail, but was simultaneously cutting 50% of the mental health beds in San Francisco general, right? So the idea was that they were like, we need to provide mental health care for people who are in the jails, because we really care about the people who are in the jails. But the thing is that the folks who were most likely to be put in the jails were folks who were street-based, but then they wouldn't put them in housing, and then they were cutting the mental health beds in the clinics and the spaces and the hospitals that people could access of their own free will. So currently, we're still in that struggle. We're fighting against the next proposal that they replaced the jail with. So we stopped the jail last year in December, and this year we've been fighting against what's been called the Behavioral Health Justice Center, which is essentially 4 floors of mental health support, some of which is locked for people who are inside. But it's this made up thing where they're like, the DPH and the sheriff will have joint power over this facility, even though technically that is not in the state of California possible. Are they going to be patients, or are they going to be prisoners? And so we're pushing back about saying what is going to truly make our community safe is scattered site housing, people have access to, that have mental wraparound services for folks. So stay tuned for how that goes.
Hi, good afternoon, everyone. How are you? Good. You sound good. So I'm Solange Gould. I work at the California Department of Public Health, Office of Health Equity, where I'm the policy unit chief. I work for the state, and our policy unit has 3 major programs that we work on. One is our Health in All Policies program. The other is our Climate Change and Health Equity program. And the third is our Government Alliance for Race and Equity. And our mission is really structural competence in California state government. So it's to work for policy, systems, and environmental changes that will improve health, equity, and environmental sustainability across California government decision-making practices and policies. So we really work, fortunately, in the most upstream place possible in public health. We work on those systems, structures, and policies that really shape our living environments, that shape the health outcomes, health inequities, and that also create these wicked problems that we're dealing with, like climate change. We do this through cross-sectoral collaboration, and I'll give you a bunch of examples of that. We also convene and facilitate multi-sectoral discussions on complex cross-cutting issues like questions about land use, schools and health, parks and greening, climate change. For example, we work to make sure that all of our cap and trade money that is majorly investing in infrastructure and will really be a huge force in shaping the face of our communities for the next 50 to 100 years, that huge flow of money in our state should really benefit communities facing inequities. So some examples of that are that all of our cap and trade money should have a piece attached to it that is about developing good living wage jobs and training in communities that are facing inequities. It should build affordable housing and do community development work without displacement. It should create parks and greening. It should preserve our ag land, etc. So our health and all policies work, through that work we convene 22 state agencies and departments to integrate health equity and sustainability. And what I really wanted to do today, I don't have any beautiful visuals for you, but I would love you to envision an organizational chart of the state of California and think about all the things that make the state of California work. So you've got your criminal justice systems, you've got your education systems, your land use systems, your transportation systems, housing, economic development, labor and workforce development. Let's go on and on. I mean, I want to put it up because it looks like a tiny, it looks like a stippling drawing where each dot is one of our agencies and departments in California. And that's actually really important because the way that we structure our government is also one of the structural drivers of health inequities in California. And so to the degree that we're able to actually unsilo all of those little tiny boxes that don't talk to each other but that deeply, deeply intersect and deeply, deeply impact each other is going to have a huge impact on the way that we can be change makers in California. So we need to learn how to talk to each other, how to use each other's skills, how to understand each other's skills, and to work together in the ways that these things are all co-occurring, intersecting problems. And then finally, we work to increase local health department and our California Department of Public Health staff ability to work upstream and do innovative public health practice. Believe it or not, our public health practice is still working really hard to get upstream, and we have a long way to go. And then finally, we conduct research showing how changes to the social determinants of health can improve those health outcomes and feed that research to the state agencies and departments who have authority over all that resource and funding flow, and also feed that research to the advocates who need the information on the health impacts for their work as change makers. So we approach this work with a bunch of principles that are very important to us. And they've been mentioned throughout the day today, but I think they're worth repeating. So first of all, equity in health benefits everyone, and equity benefits everyone's health. Population health outcomes are primarily the result of social and political forces, much more than genetics, lifestyles, or behavior. Reducing or eliminating health inequities is going to require attention to the root causes of social injustice, looking at the fundamental causes of social, economic, and political equality. It's going to require organizational transformation, and dominant public health paradigms are limited in addressing health inequities because the sources of those inequities remain outside the traditional scope of public health work and its methods. So public health practice now, in this era, requires a shift towards addressing those multiple interconnected social determinants. And this has a huge implication for what happens at UC Berkeley. Addressing health inequities requires a life course approach and a systems approach. And addressing health equity requires a multi-sectoral approach and the cultivation of partnerships across government, outside government, and in communities facing inequities. So I'll tell you a little bit more about health and all policies. I know 5 minutes is going to go by very quickly. What's that? Oh, good. Am I already done? Okay, I have 1 minute left. So I guess we'll just wait till the question and answer time. But I wanted to say one thing that seems really important to me, which is that we have a lot of what we call wicked problems, right? And so when you look at those wicked problems, those problems that seem so hard to change, and climate change is one of them, you look at them and you see that many of them share the same root causes, which is the unequal distribution of power that we've been talking about today over and over and over. And that unequal distribution of community power and power between people and corporations and people and government really shapes systems, and those systems together create those living environments that in turn create unhealthy living, social, and economic conditions. And all those things shape health inequities, climate change, all of those wicked problems. So in our area of influence, we need to think systemically. And I want to end my time with the idea of the birdcage that Donella Meadows has written about, where, if you think about the multiple strands, I work for the California Department of Public Health. That's one strand of a birdcage. The criminal incarceration system is a strand of the birdcage. Education is a strand. And each institution or system is working together, mutually reinforcing each other, adaptive to each other, adaptive to changes in one of those strands. So if I, in my little public health world, am just working to cut one of the strands and to change those inequities just in public health, all those other systems are going to adapt and recreate the oppressive birdcage. And so we need to be more skillful in our era of practice to think multi-systemically. And, we need to work across education, land use, housing, city planning, criminal justice, civil rights. We need to have our students have all of that training together and have a multidisciplinary training practice where we really can approach social equity and public health in that way. So I guess I'm out of time. All right.
Thank you, Solange. Rupa Marya.
Hello, my name is Rupa. I am a faculty member at UCSF. I'm a hospitalist, part of the Division of Hospital Medicine, internal medicine doctor. And I'm the faculty director of a very new coalition called the Do No Harm Coalition. And I see us as the anti-capitalist, nonviolent, direct action militant wing of people at UCSF. So we are by far the coolest group there. And we formed in response to the Frisco Five going on hunger strike in San Francisco. And basically what happened was I was heading up to meet with the Vice Chancellor of UCSF to ask him to issue a letter to the city of San Francisco denouncing the violence of the police towards people of color and the mentally ill in San Francisco. And on my way to that meeting, I saw these people on hunger strike. I didn't know it was going to happen. I'm pretty tied to the communities in the Mission District. And so I went to meet with them after several days of watching to see that, what was going on, and offered them accompaniment in their struggle and safety from a health perspective. We mobilized the resources available at Clínica Martín Baró, which is a free clinic run in partnership by UCSF and San Francisco State students, primarily for undocumented patients, but available to all. And they took us up on that, and it was a beautiful experience of creating a direct bond and walking in solidarity as a physician and using my white coat privilege, what I call my white coat privilege, to speak on behalf of people who were putting their bodies on the political line. And when we're looking at these injustices, and very much so in Standing Rock right now, these are issues of bodies. These are embodied issues, and us as physicians need to be able to address them at the level of the physical body and the level of the social body, the body politic. And so this is the kind of thing that we're addressing in our coalition. So we've defined ourselves as people who are committed to ending racism and state-sanctioned violence. We see racism and state violence as public health emergencies that physicians absolutely need to get involved with in many different and creative ways. Around locally, issues of police violence and racism, we have several different initiatives we're working on right now. One of them is training ourselves and opening our own minds to how we can be healers and how we practice medicine and what the definition of medicine means to us. So part of my own background, I've spent the last 10 years working. I've always worked 60% at UCSF, and for 10 years I toured with a band called Rupa and the April Fishes, and we've toured in 28 different countries, and I'm drawn to hot spots where I can see. I use my music as a way to go in and witness what's happening with people, and where the intersection between society and disease happens, between social groups, structurally vulnerable groups. So through that experience, I feel I've amassed a really great coterie of friends from many different traditions who are now coming in to train some of the Do No Harm Coalition, the med students and nursing students and midwifery students and staff. And so we did a training recently on tactical performance by UC Davis professor, theater professor Larry Bogad, and it was an amazing experience where we were looking at power dynamics in our own bodies and recreating these tableaus of power dynamics that we exist in and power dynamics that we want to see change. And so often physicians in training, health workers are training up here in our minds, and so to bring that into our bodies, into a different articulation and understanding of what it is that we're actually trying to change, it's opening new ways of thinking about the struggle that we're dealing with. We're also involved in getting ourselves implicit bias training, anti-oppression training, increasing our own vocabulary around these issues, and increasing our scope of skills so that these young health workers have a different kind of vocabulary that's not simply couched in clinical language. We've been working with the coalitions based primarily in San Francisco who are seeking justice for victims of police killings. So making those ties, just making friends basically, and standing with people and learning what their struggles are has been a tremendous thing to watch our students engage with. We're also working on an initiative to get police killings to be a mandatory reportable condition in the state of California. And exactly. If we can do it for influenza and syphilis, we can do it for police killings. So that is something we're working on. Folks here who work for the Department of Public Health, the Department of Health in California, I would love to talk to you more about that. So we've been in conversation with Nancy Krieger out at Harvard about strategies to do that either through a law or through working directly with state epidemiologists to make a case definition. Another thing we're doing is working on a research question that was handed to us by the Justice for Mario Woods Coalition, so a group that's organized around seeking justice for him. He was killed in December of last year. And I find it fascinating to receive a research question from a community group. And the question is, what are the health outcomes? What does it do to a community when there's an open wound and the only medicine is justice, and that justice is not given? We cannot get the medicine we need to heal this wound. And what are the health outcomes? And so we are now working with public health folks. I have no idea how we're going to answer this question, but we are going to answer this question. We're going to learn how to ask it, and we're working with some very creative public health folks and students to start looking at this question together. We're also working very closely around the measures for the criminalization of homelessness and the mentally ill in San Francisco that are up. And we are also working with San Francisco General Hospital, an initiative to remove the Sheriff's Department from San Francisco General Hospital based on several concerning dynamics that medical students and residents have been reporting and witnessing. One of them is extremely newsworthy, and I'm not at liberty to talk about, but wait for the national news to hear about this one. So there's a lot of activity happening in our organization, which is why our website is totally out of date. We have a direct action group where we're training ourselves to be ready for police killings that come up so that we can mobilize ourselves and use the symbols of our profession and the moral gravitas that we carry as people who have the privilege to witness and walk by people in illness and walk by them in their suffering. And we have also been working on media communication, how we can train our students and staff to be very quick and very agile in communicating these issues from a physician's, health worker's perspective. In addition to the work on police violence locally in San Francisco, in August of this year, a month and a half ago, I was called by a local indigenous person who witnessed what we were doing with the Frisco Five when he was out at Standing Rock, and he said, "Rupa, they pulled our water supply here, they've militarized the roads, we need help, we need medical help, can you come out here?" So in September, I went with a core group of 3 Do No Harm Coalition members, 2 medical students, 1 recent family grad, and we assessed the health needs there at Standing Rock. And at the invitation of the tribe and tribal healers, we have formed a coalition together with National Nurses United, the Global Healthcare Alternative Project, their tribal healer, Linda Black Elk, the director of their IHS hospital, Sarah Jumping Eagle, who trained here at Stanford, traditional Chinese medicine practitioners, Changing Woman Initiative, which is a Diné indigenous midwifery initiative. We're building birthing TBs out there. And then UCSF would be providing the allopathic aspect of this integrative free health clinic for the development and practice of decolonized medicine. And so that is something that we are actively doing right now. I'm so grateful to Seth Holmes and the JMP students, as well as the Native American Health Alliance at UCSF, those students for helping us to develop this curriculum. I was just there for the last few days to have listening sessions with elders in the community to hear their understanding of what they call Wasichu medicine, or white person medicine, and that word from Lakota literally translates to the one who takes the fat, or the greedy person. So it was a totally humbling experience to hear how these people think of our medicine before we even enter clinically, just to understand how they're going to see us, given the historical trauma and the ongoing colonial trauma which is happening there right now. So this clinic that we'll be forming is going to be called the Mini Wichoni Health Center. Mini Wichoni means water is life. And it will be a long-standing clinical partnership that we are entering and we are fundraising for right now. So come talk to me about that. I think my time is up. Right? Is it up? Okay.
Yeah, absolutely. Okay, so I just thought I'd start with this image here of us participating. I work for National Nurses United, CNA, in our education department, and our education department and our programs have a tight relationship with the rest of the work that we do as an organization that's pretty much all geared around addressing the structural determinants of health and social inequalities. And we are really happy to be here today participating in this conversation because, as so many have mentioned today, the really generative possibilities of having this shared language together, these shared set of concepts that allow us as an organization to have a new name, right, for a kind of a course of action and approach to both education and care and activism that at times we've struggled to name. We variously called revolutionary nursing or social movement unionism or solidarity education or all of the above. And so it's just really an honor to be here participating with everyone today. So being from our education initiatives, as I am, I just wanted to make a quick comment about that. Kurt mentioned a new program of ours. All of our education initiatives go beyond traditional labor education as it has been understood, as kind of professional development, labor relations, and so on. And this program we have developed in partnership with Adrian Pine, which I know many of you know, in the public anthropology department at American University. So if anybody's interested in talking about this, we can talk about this either in the questions or afterward. But I want to mostly spend my time highlighting how our education programs, which consist of these kind of higher education partnership programs, which are really more or less explicitly structured around a structural competency framework, and provide, as far as I know, is a pretty unique opportunity for nurses now to come into this conversation with clinicians, with students of various backgrounds, and to deepen this conversation. We also provide continuing education for our nurses, and we have for a long time, and these classes also focus on similar issues. So what I want to highlight is how this kind of structural analysis and approach to social justice that runs throughout all of our programs at the union has its roots in our organization's kind of long history of engaged social struggles, which began at least in the 1990s when the education department itself emerged out of kind of an effort to understand and help nurses understand and respond to the wave of restructuring that accompanied the HMO movement of the time. And it was at that time that we realized, that nurses realized, that it was insufficient, it would be ultimately insufficient to only respond to the effects of marketization of healthcare and eventually start to intervene in the structures driving that marketization. First step was to try to regain control of the labor process in the hospital, the process of providing nursing care, and the way that we did that eventually successfully after a long struggle was to secure safe nurse-to-patient staffing ratios in the state of California. And we've continued to build on that kind of understanding that we need to intervene on these various structural levels. Let me catch up with this here. So among other things, we've over the years participated in many campaigns to try to keep public hospitals open, keep them from being privatized, some successful, some others not. And this is all based on our fundamental conviction that everyone has a right to access to full access to medical care in their community, and to shut a hospital down like Doctors Medical Center in Richmond, or to attempt to do so here in Berkeley at Alta Bates, is tantamount in vulnerable communities, it's tantamount to medical redlining. And so we are working to help stop that from happening here in Berkeley. So that's kind of one of the things, and this is based on this idea and this understanding that we've long had, that we need to advocate for our patients, both at the bedside and beyond, in cooperation with the communities in which they live. So, you know, we've fought these uphill battles and haven't always been successful. Often we have. And like I said, all of them are based on this idea and this notion that ultimately we have to address the structural roots of the health and social inequities that affect the health of our patients and also our profession. And that will ultimately mean decommodifying healthcare itself, which is why our kind of cornerstone campaign is a supremely, I guess, impractical one, as maybe RadMed would have put it. But nevertheless, it's absolutely necessary. And not only this, but our ultimate goal is to intervene and affect the political economy and the social structures that shape not only healthcare but our society as a whole. So I'm just going to outline a couple of the more recent efforts that we've been engaged in, including the campaign for Proposition 61 here in California that would cap the cost of prescription drugs for the state of California at the same rate that the VA pays. And so, you know, we've taken a leadership role in this campaign along with the AIDS Healthcare Foundation, not only for the potential that this type of reform would portend for, you know, for affecting, for making more accessible the skyrocketing of the price, these drugs whose price is skyrocketing for vulnerable patients whose, of course, incomes are remaining stagnant or even decreasing, but also because we see it in a first step in a process that would eventually tip the balance of power within our healthcare system away from the corporate interests that currently shape it and in favor of patients and their advocates, nurses and clinicians. So our efforts to address the short-term consequences of health as well as the long-term consequences of environmental degradation and the long-term health consequences and social consequences that result from that have led to various types of actions here in California as well as across the country, including our participation in campaigns to block oil by rail projects here in the East Bay, in San Luis Obispo County, help block the coal export facility in Oakland in cooperation with a number of different community organizations here. And of course, as Rupa mentioned, we're also trying to help the water protectors in Standing Rock to stand up, not just for, of course, the health consequences of the environmental effects of a runaway fossil fuel industry, but first and foremost to reaffirm and aid Native peoples in their ability and their endeavors to protect themselves, because that's what this struggle is about first and foremost. Okay. And so just to wrap up then, we've been cooperating, as Rupa said, in establishing the clinic that she was talking about, and also sending nurses already out there. We've had various nurses deployed through a program of ours called the Rapid Nurse Response Network. And they have been there for a couple of months now and continue to provide first aid and basic care to water protectors there. And this is part of a program, RNRN, that's been around for a few years now, emerged out of a grassroots nurse-led effort to respond to the devastation in Southeast Asia after the tsunami, and then continued on where we have not only sent nurses on deployments abroad, but also here domestically, including at various Occupy encampments around the country. We were one of the first tents to be erected in Zuccotti Park. We were here in Oakland for a couple of months as well. And I just wanted to mention some of these efforts and really just highlight the fact that we understand care, first and foremost, as something that happens in solidarity with the patients that our nurses have promised and committed to care for and advocate for, and that we understand education, labor education, continuing education, higher education for our nurses as an opportunity both to deepen the understanding that they derive from that committed practice, as well as an opportunity for them to develop the critical thinking skills and the ability to envision ever more effective responses to the consequences of health and social inequalities that they see at the bedside every day. So I'll leave the rest for comments and discussion.
Hi, y'all. I have the glorious task of going almost last when you all are mostly saturated, and I'm so humbled by all of that I've heard today and these fabulous folks that I'm half speechless. So we're trying to get through it together, right? So I'm here to talk to you about OPP. How many of y'all know about the radical organization called Critical Resistance? Awesome. If you haven't, check them out. Local chapter in Oakland. So the Oakland CR chapter responded to the community who were basically asking, like, we need some ways to keep ourselves from being harmed by policing. And so Critical Resistance went out into the community and did some interviews, and one thing people said was, we need to know how to better respond to crises. So the Oakland Power Project's first project is this workshop that we have created together. So they put out a call, Critical Resistance put out a call, and we're about 20 of us, give or take, depending on the day. So people are coming from public health backgrounds, and herbalists, acupuncturists, therapists, we had an osteopath for a minute, nurses, to come together and create some curriculum that we can then bring out into communities. We ended up with 3 different foci. So I'm coming from the behavioral health group. Then we also have a group that's focused on exacerbations of chronic conditions, and another group that's focused on accidents. So we put together this curriculum with the framework of decoupling policing and healthcare, right? So I'm a therapist. I train people in behavioral health. So I know and believe in the core of my being that people can have a change of heart, attitude, and mind. And I also believe that policing is a job that's all about controlling folks of color, folks who are not documented, poor folks, and people with mental illness, and queer folks. So if that's your job, then how can you also be there to help, right? So, and as long as those shady policymakers keep making these policies that are like, well, police are first responders, then the money that could go to all these great public health programs end up going to the police. You may know that Oakland has this really ridiculous ratio of money that goes to policing, more than any other, most other cities around. So, just to make that kind of brief, I know we're all running out of time, but we have these 3 workshops. We can come into your community, your workplace, your neighborhood, whatever that looks like for you, and help people. The idea is that you should walk away having spent some time critically thinking about different ways to respond to crises that lower the harm that could come from policing as first responders. And it's not just, the police on the streets. I think Robbie mentioned this. We also have at Highland Hospital, where a lot of our psych emergencies end up going, we have a sheriff's station right there, right as you walk in the door. So, policing is sneaking around all kinds of places where we should be having health. What else did I want to say? So the workshops are 2 hours. If you're interested, you can go to the CR Oakland website. There's a place where you can request those. If internet's not something that works for you, you can also see me and I'll get you other ways to get in touch with them. Anything you want me to? Good. Cool. I want to keep that brief and just leave it for comments or questions afterwards.
Our final panelist, Katherine Schaff.
Yes. Hi, everyone. Thanks for hanging in there. I'm Kathy Schaff, and I am going to talk about 2 areas today. I'll try to go quickly since we're right up against time. I'll talk about my work at Alameda County Public Health Department and some of my dissertation research related to this, and a voluntary group, Occupy Public Health. And I just want to mention today that what I'll be talking about represents the work of a lot of my colleagues, staff, people in the audience, friends, and just to acknowledge I'm a messenger, but really representing a whole body of work by many other people. So to start off at Alameda County Public Health Department, we have a lot of ways that we are working towards health equity, but because today's panel is focused on community justice, I really wanted to lift up our role with community partnerships. And just some quick background on our health department. In the 1990s, Arnold Perkins, which some of you may know, he's an amazing leader and super inspiring person, really pushed the health department to start looking at our clients, to view residents not as clients but as partners, and also pushed our staff to see ourselves as public stewards and servants. And at the time, this was very revolutionary for a governmental public health department and has really evolved into where our work is today. And that's one of the main points I want to make, that in the public health field, and I'm assuming in a lot of the other fields out there, we often hear about how government agencies or universities or public health nonprofits can help build community capacity. And while that we've seen that our health department does have resources it can leverage to help communities fight for their health, I want to flip what we often hear and instead talk about how our partners, like Casa Justa here, have built our capacity to address racial and health inequities as a government agency. I gather from that this is an approach people are already thinking about, but I wanted to make it explicit because I think there's so many things pushing us to go back to the traditional route, and so we need to keep raising it up and being explicit about it. So I work on Place Matters, which is our local policy initiative. We focus on housing, land use, transportation, economics, education, and criminal justice, and the link to health equity. We started this in 2007, and when we started, we had capacity around understanding how social factors affected health based on research and data, but we had very little capacity to turn this into action, especially in the local policy arena. And in our housing and land use work, which I just want to honor my colleagues Tramwin and Anna Lee because they've done so much work in this, we've been very fortunate to work closely with Causa Justa and other partners, starting with a focus on the foreclosure crisis and then evolving into a focus on the housing crisis, development, displacement, renter protections, and poor housing conditions. And so in my dissertation, I wanted to understand why our health department had been able to engage in this work, and then also look at some of the other barriers that health departments were facing and why we weren't seeing this in more health departments. So I focused in on the foreclosure crisis and used this to examine it. And what became very clear was that our partnerships were essential to us taking on foreclosure as a social determinant. And so some of the key things that I found about how partnering with groups like Causa Justa helped build our capacity include helping us to deepen and evolve our own framework. So we already had a framework around health equity in our workplace, meaning both a tangible document with a framework on it, but also an organizational culture that valued social justice, that prioritized community-driven change, and that focused on addressing power dynamics. But working with Causa Justa kept pushing us to evolve this, to sharpen it, to, especially in the area of racial justice, be more explicit and be able to articulate that. And so we continue to evolve through working with them. Also in the beginning, our community partners were the ones to alert us to windows of opportunity in the policy arena and help us understand the political landscape. Housing policy is extremely complex. We could not have done this on our own. And what we heard staff say is it's a very steep learning curve, and so most of what we learned came from our community partners. Also, they alerted us to really looking at nuanced solutions. What the media reports on housing solutions is not what we need. And so they really drove home to us thinking about renter protections and preventing displacement. Another way that our partnerships have been essential is that we've each played different roles. I can talk about this a little bit more, that have made us stronger together, and we've been able to really think about what is our role as government and how is that different, and what do we need to do to leverage our role, but how do we also check ourselves and try to hold ourselves accountable. So there's a lot more I can expand on, but I just want to reiterate that we couldn't have done this work without partners. And I know not everyone here is at a local health department, but whether you're in a government agency, a university, or a nonprofit that is not a base building resident-driven nonprofit, I think we need to continually think about how we build these partnerships and use our role to support communities in shifting power, increasing government transparency and democracy, and achieving racial and health equity. So now I want to shift to another area I've been asked to speak about. And while this work was happening in Alameda County, there's also been, as many of you know, a ton of progressive work happening in the Bay Area in public health. And so a loose collective of us formed called Occupy Public Health. We're a group dedicated to working together at the intersection between public health and social justice. And there's a lot of people in the group connected to organizing in multiple areas, so it's also a place to learn how to plug into different areas. So it started in 2010 as a health and human rights learning circle. We wanted to think more about using a human rights frame in our public health work. And some of the original groups were the People's Health Movement, Hesperian Health Guides, Catalyst Project, other public health departments and nonprofits. And I just want to lift up what I think is extremely important about it. These groups are also focused on community power and ending racism. And especially groups like Catalyst Project have an explicit focus on racial justice. And this shaped both how we work and the topics we took on. So as the Occupy, or later became much more known as the decolonized movement, spread across the world, we started trying to talk about how the areas being lifted up like inequality, income inequality, housing, immigration were public health issues. That sort of we stopped meeting for a little while and then reformed in the fall of 2014 after we saw the organizing happening in Ferguson and the Black Lives Matter movement. And I think that for many of us, when Mike Brown was murdered and we saw the way the police and the government responded, it was such an affront to the very idea of public health, and that if we were to build a society from the bottom up, we would never build in police and state violence, and we would never build in structural racism if we wanted to have healthy communities. So we exist in a place where that is the reality, and as public health people, we were trying to grapple with what is our role. And at the very first meeting, what a lot of people said that they wanted out of the group was a sense of community among public health workers to support us in thinking through how we can undo this work. And I think that's one of the biggest things we've gotten out of it. I just want to briefly mention a few things we've done. We've organized public health contingents at marches and direct actions, sometimes a larger group, sometimes it's just finding a buddy. We have a Facebook page. People post, I'm going to this, I'd like someone to go with me. We've co-organized a panel. We partnered with Alameda County Public Health Department staff on Black Lives Matter and public health. We've had some guest speakers like the Central American Resource Center. We'd like to do more guest speakers. We've done some fact sheets around the Fight for 15. Some people testified about the public health impacts on police violence at the San Francisco Blue Ribbon panel. A subgroup created a statement and petition around Urban Shield and is continuing to work on that. And we just had a happy hour where we looked at a lot of the ballot issues from a health equity perspective, which is the results are on our website. So we're loosely organized. We meet once a month. We rotate roles. You can bring forth ideas, ways to plug in. We want to see how we can both support movements that are out there and influence and organize our own public health field. And for next steps, we would like to do a study group around the Movement for Black Lives Matter policy platform, or the Movement for Black Lives Policy Platform, and are looking to partner with other organizations. And we also, some of our members are connected to the groups here today, but we'd love to talk about how we might be able to leverage the power of all these groups here today, like RadMed, Do No Harm, and some of the other groups. So I'm going to make people do this, but can the members that are here, there's quite a few people, stand up, just if you have more questions, former or current members, these would be great people to talk to. And I just want to end with what's been critical in both the health department and this group, that we've had members who are really vested in community-driven change and in fighting racism. And this has been really critical for making change. In terms of what we can do, I think that we have an obligation to name racism when we see it. We have privilege and power as public health workers, and there's a lot of people out there not saying that, and so everywhere we can, I think that is one thing that we absolutely can do, is name racism. And as we grapple with how we do this work, we can at least name it and be clear on it, and then get other people to speak up on it. Thank you.
I want to thank our panelists once again. So I am aware that it's 5:30, and con su permiso, or with your permission, I think I would still like to continue with a brief discussion, question and answers, and some closing remarks. Now, I just want to begin by noting that Solange offered us, she reminded us of the metaphor of the multi-strand cage of oppression, which for Woods is not a metaphor. It's a real cage that oppresses transgendered bodies as well as other bodies. Robbie mentioned ever so briefly the Reagan administration, and while you can't blame one administration if you had to, this is where wealth inequality on steroids began. This is where community resources and government resources were slashed horribly, where Reagan was calling out welfare queens destroying the economy while promoting corporate welfare kings. Rupa mentions a couple of radical things: medical people talking to community folks, making friends. I love that idea, and decolonizing medicine in the process, and discovering that justice may be the medicine that we need for social ills. Chris continues with decolonizing nursing care and advancing the concept of medical redlining. Isn't it a great concept? It explains so much of what we're seeing, and of course urges us to organize, and the question is how, of course. Megan mentions critical resistance and the radical notion of decoupling health and policing. Reminds me of Victor Rios' work on the youth control complex and how we got to get cops out of elementary schools and junior highs and community centers, because we don't need them to be intervening when, you know, a 15-year-old African-American girl is feeling a little bit stubborn about her cell phone, or when a young 12-year-old Latina is arguing with another Latina. We don't need police intervention in the public schools of San Antonio. And then Katherine, as you just heard, reminds us that building public health capacity is going to depend on teaming up with our community advocates and activists to address so many things like place mattering. With that said, there's so many questions that could be asked, right? I was just like you. I was just trying to connect some of these dots, because I think ultimately we're going to have to connect those dots to take on the immense, entrenched and complex structures that continue to oppress people in terrible ways. Not sure where to start, you know, in terms of my own questions and answer. I think I was just trying to connect those dots and maybe wondering, you know, the meta question is, so how do we take all of these progressive strands? How do we organize them, as Chris mentioned, and start to destabilize some of these structures that bother us so much? I think that's my main question. I think with that, you know, anybody who would like to answer, I'm happy. There's a couple of microphones on the table. I would love any of your thoughts on that, because I think it's exactly this kind of panel and these kinds of diverse expertise that we're going to have to combine in some synergistic way to take on these immense structures. Anybody want to tackle that? Would you like me to repeat the question? Just kidding.
And I mean, it would also be good to hear if there are other questions, because just acknowledging that, I mean, we just put out a bunch of stuff and we spent a lot of time talking. So if, you know.
So we have a couple of floating microphones in the audience, correct? I see one hand back here to my right. Can we hear from that person?
Hi. I had a question about the documentary that was done about Highland Hospital quite a while ago. Just showing, just what a great hospital is. And I was curious, did that come into any of your research? Are you still showing it? Because it was just a good way for people to understand that Highland really did take care of people. Do you remember this documentary?
Yeah, it was like a day in the life of Highland
Yeah,
Hospital,
right.
right? So all the trauma centers going on and waiting room. Yeah. The waiting room, I think it's called, right? Anybody see that, or any thoughts about that?
I think our EMS did a showing of it, Alameda County Public Health Department.
Well, it's a good resource for everybody just to see it.
Thank you.
Thank you for that reminder. Okay, we got a person up here in the front row, second row, excuse me, to my right. Then I think there was somebody back there, right, that had their hand up. Okay, maybe we could get the mic to that person next.
Hi, thank you everyone for the presentations today, everybody that spoke. I just wanted, I'm a librarian, social justice librarian.
Nice. That's the only kind there is, right?
I wish. So I wanted to encourage everyone that spoke today and everyone in the audience to think about the public library in a larger way than you probably do. We have a stereotype of libraries in our society as someplace where you go and you have to be really quiet and it's all about books. And there are a lot of librarians that are doing work just like the work that you're doing, reaching out to community agencies. I do a lot of work. My research is on LGBTQ youth homelessness in public libraries. So I just wanted to really encourage you to think about libraries. If anybody has any questions about how to go about that, I'd like to.
Which library are you at?
I'm not anymore. I'm just starting a nonprofit called Mind the Gap that is about social justice and public librarianship, but I was a library for 20 years. I did jails and prisons and a lot of other work. But anyway, there are a lot of us out there, a lot of librarians that are interested in social justice work and coming up against some of the same problems that you are, doing a lot of the same trainings.
And you can check out the waiting room DVD at the library. Thank you.
All right, thanks.
So we had somebody back there, and then I know we have a hand up here. So the person in the back there.
It's not on.
Hi. I'm from Sacramento. I'm a social justice organizer on multiple issues, but with the Structural Competency Working Group, I'm working on disability justice, harm reduction, and a paradigm shift in mental health. I see some medical students and social work students I know.
Nice.
Thank you so much, panelists. I wanted to say there's been quite a few references to the harm that healthcare policies have had in their relationship with law enforcement and mass incarceration. And within the movement for civil and human rights in mental health, there is now finally an organizing effort underway nationally to address systemic racism, ableism, and state violence that targets people of color and women and many other marginalized folks who also are in mental health crises or experiencing extreme states or emotional distress. So I wanted to comment because I've heard a number of folks refer to the Reagan era deinstitutionalization or the closure of many state hospitals as being one of the factors that led to present-day injustices and the targeting, the disproportionate targeting of people in emotional distress by law enforcement and jails and prisons. And I just wanted to comment that I would like to see more inclusion and discussion between the different partners on this and an active inclusion of people with lived experience who have been out on the streets, who have experienced that kind of state violence and who have been in the jails and prisons, because our voices are not yet being included. And one of the comments that you're likely to hear when we are included has to do with the reliance of hospitals and force in psychiatry and coercion in mental health, as that is being posited now as the only alternative, the necessary evil in that would replace jails and police intervention. And we don't accept that one form of coercion and force is necessary to replace another, that one type of institutional control is necessary. So I'd like to hear anyone's comments on this topic, because it's an important one that's often overlooked.
Thank you.
Yeah, what you said. But, you know, when I think about this proposal for a mental health jail in Alameda County, and I hear $3 billion are going to that, and then I allow myself to dream what I think could happen with $3 billion to serve folks with mental illness, substance use, trauma, et cetera. And I don't think more hospitals is what I come up with in my dreams. And certainly inclusion of people who this would directly impact is definitely high on my list of things that I would dream about. And I think that there are lots of other solutions besides hospitals, lots of other places people can live, lots of other supportive housing, supportive employment. I think there are lots of things we could dream up with $3 billion. So for me, it's not replacing one awful idea with a bunch of other awful ideas.
And also just want to note that my comment on that was by no means saying that the hospitals were better or should be where we want folks to go. It was just to bring up the fact that that was being coupled with a number of other ways that the federal government and also the state government have been taking away certain types of services and not replacing it with something that's actually better. And I think just one thing I want to add to that is that I went to Cuba, and I went to a mental health facility in Cuba, and it looked like a fantastic elementary school. There was like a huge track, and it was beautiful. I mean, there were trees. I mean, it was fantastic, right? And so I think that there are models out there, and there are ways that we can be doing things that are actually about, like, we talk about this concept of human development, that are actually about like giving people the space to live in their full humanity, regardless of who they are, their identities, their illnesses, etc. There are ways that we can actually do that and create that.
Thank you. We had a question over here.
Yeah, hi. First of all, thank you to all of you. Totally inspiring. You're doing the structural work. I really, really am inspired by you. Second, a question about race. The comments that came out at the last panel made me think that there was some anxiety that race could be lost in the language of structural competency, the focus on race, which is ironic since structural competency really came out of a concern about race and wanting to replace a model of cultural difference as the cause of inequalities with structural racism. So I just want to ask the panelists whether you have that anxiety. Is there something we need to be concerned about as we decide whether or not to move forward with the language of structural competency, that somehow race would be lost? And if so, how do we correct for that? Given that, of course, we're concerned about intersectionality, we're concerned about many different axes of oppression as well. Great question.
Let me see if I can take that on. That's a doozy of a question. That's difficult. So what I was something I was talking about earlier was like thinking about prisons and policing and the administrative capacity that goes into prisons and policing, and so thinking about the ways in which, if we're talking about structural competency, if we're talking about the way a city or a county or a state is structured, and then within that, if 40 to 50 to 60% of a public's budget is going towards caging and controlling Black people, Latino people, Indigenous people, poor people, queer people, trans people for being themselves in public. And instead we are pushing for that administrative capacity to be structurally shifted towards what is going to promote health and well-being, then I think that is the top, like that's the shift that has to be made. Unfortunately, that is not the political priority of most politicians, hence the phrase tough on crime. Like that is how the United States solves its problems.
That came from Reagan, you know.
Speaking of Reagan.
Could I add one thing to that?
Yeah, please do.
Sorry. So our health department is also involved in an initiative called the Government Alliance for Race and Equity, and we've been fortunate to be able to have conversations about this. And one thing they've talked about a lot is how much racism evolves. And so I think we all, whatever terms we're using, structural competency was a new term to me in coming to this conference, but we use social determinants, we use health equity, and I think in any area of language, because racism evolves, that's why, I say we need to name racism, because it always gets left out, and sometimes it's explicit, but sometimes we're just so conditioned, and our structures that we work in are so conditioned that if we don't consistently name it, and I think these opportunities to come together, to hold each other accountable, but to also support each other in learning how to name it, it will get left out no matter what terminology we use. And so really investigating that, really figuring out how to call it out, how to name it, and then how to build solutions, because you can name it as part of the problem and then it's absent in your solution. And that's really hard work, I think. It's something we struggle with. And so I think being able to come together and really name it and just consistently do that is important.
I'm going to invite you all to continue this question and answer after closing remarks by John Balms from the Joint Medical Program, and also from Pike Long. I'd like you both to come up and make your closing remarks.
So, did you all find this conference valuable? The last question stole my line. I want you to all feel inspired like I am to go out and continue to do the social justice work that you do. And I especially want to thank I want to thank the organizers for this conference, but I especially want to thank the students that contributed. And could I have all the students stand up who contributed to this? Come on, there's many more. Yeah, students are shy here, I'm sorry. And I especially want to thank my joint medical program students, many of whom were here today. I never heard of the term structural competency till I came to the joint medical program, so you're not the only one. But I have come to realize how important it is in terms of passing the baton on to the next generation of healthcare providers. And I don't want to sound physician-centric here, because nurses have been ahead of us in terms of structural competency for a long time. But I want to give a special shout out to Rupa, in part because I've been a fan of her band for a long time, and also because she's the kind of physician that I want my joint medical programs to be. It's program students to be. So Pike.
Hi, thank you, and I guess I get to be the closer, yay. So I'm just here quickly repping DICE, which is the Diversity, Inclusion, Community, and Equity Committee of the School of Public Health, which came out of the Black Lives Matter, a response to Black Lives Matter within the School of Public Health and addressing structural inequities in our own school and in the community at large. We're having a screening of free CC along with a Q&A with the filmmaker and CC McDonald herself. So I'm inviting you all to come to that. CC McDonald was a black trans woman who was survived a racist, transphobic attack and then was incarcerated for it. And there was an international movement to liberate her. So she's free now. She's awesome. She's become a super badass activist against the prison industrial complex. And that is November 15th. And then finally, so please come, there's flyers all around out there. And then last but not least, I really wanted to give a massive shout out to both Cynthia Alvarez. So let's give her a round of applause. She's from the Institute for the Study of Societal Issues. She was a major help in putting this together. Seth Holmes, of course, is amazing. Runaway Seth. That's right. And last but very not least, Deborah Lustig, who I have flowers for her. Because she totally held this down and made the whole thing happen. So let's give everybody another round of applause and thank you so much.
Thank you, everybody. Thank you for coming. Thank Deborah for her amazing work. We're going to have networking time here and sort of towards the water, and if there are any snacks left that there might not be, for you to meet these people, find out how you can support them, find out what initiatives on the ballot, and then you is supporting what you can do for these organizations. And I want to take a picture of this panel before you leave.